Parathyroid hormone-related peptide in NETs, hypercalcemia management. Hello, this evidence-based content is prepared by Sabur Khan, fellowship-trained consultant surgeon. If you or someone you care about has been diagnosed with a pancreatic neuroendocrine tumor, a PAN-NET, and is now facing the challenge of high calcium levels, you're in the right place. I know receiving this diagnosis can feel overwhelming, especially when a rare complication like malignant hypercalcemia enters the picture. PTHrP-secreting neuroendocrine tumors represent one of the rarest forms of functioning PAN-NETs. These are tumors that not only grow, but also actively produce hormones or hormone-like substances. PTHrP, parathyroid hormone-related peptide, mimics the action of parathyroid hormone, causing your body to release excessive calcium from bone into your bloodstream. This creates what we call humoral hypercalcemia of malignancy. Why does this matter personally? Because hypersecretion of PTHrP by metastatic neuroendocrine tumors seems to be exclusively associated with metastatic pancreatic NETs and has a major clinical impact. Poorly controllable hypercalcemia is associated with increased morbidity and mortality. Early recognition means early intervention, which can dramatically improve your quality of life and outcomes. If you have a pancreatic neuroendocrine tumor and your calcium is high, the first thought might be primary hyperparathyroidism, especially if you have multiple endocrine neoplasia type 1 or MEN1, a hereditary syndrome. Primary hyperparathyroidism is actually a key feature of MEN1 syndrome, affecting up to 80% of patients. In the absence of elevated PTH levels, that's intact parathyroid hormone, and bone metastases, humoral hypercalcemia of malignancy due to ectopic PTHrP secretion should be investigated by PTHrP measurement. The diagnostic criterion is straightforward. PTHrP greater than the upper reference limit, with suppressed PTH, indicates humoral hypercalcemia of malignancy. This distinction isn't academic, it fundamentally changes your treatment approach. Primary hyperparathyroidism might require parathyroid surgery, whereas PTHrP-mediated hypercalcemia requires addressing the underlying neuroendocrine tumor, along with supportive calcium management. Hypersecretion of parathyroid hormone-related peptide by metastatic NETs has a major clinical impact because poorly controllable hypercalcemia is associated with increased morbidity and mortality. In such cases and other rare syndromes, early diagnoses and management are essential. What does poorly controlled high calcium actually do? It can cause profound fatigue, confusion, muscle weakness, kidney problems, heart rhythm disturbances, and, in severe cases, life-threatening complications. If you're supporting someone through this, watch for increasing lethargy, excessive thirst, or changes in mental status. These warrant immediate medical evaluation. In PTHrP hypersecreting pancreatic NETs, supportive therapy includes hyperhydration with oral and intravenous fluids, Denosumab, and zoledronic acid. Hyperhydration means aggressive fluid replacement, often 200 to 300 milliliters per hour of intravenous saline initially. This dilutes the calcium and helps the kidneys excrete it. Denosumab and zoledronic acid are bone-targeted agents that prevent calcium release from your skeleton. Think of them as brakes on the process driving your calcium up. These are typically given as intravenous or subcutaneous injections. The 2023 Endocrine Society Clinical Practice Guideline on the treatment of hypercalcemia of malignancy provides detailed protocols. Calcitonin and loop diuretics constitute second-line options for refractory humoral hypercalcemia of malignancy. When first-line treatments aren't enough, calcitonin can provide rapid but temporary calcium reduction, and loop diuretics like furosemide help increase urinary calcium excretion once well hydrated. These are reserved for difficult cases because they require intensive monitoring. All the calcium-lowering treatments in the world are temporary measures if we don't address the source. Management of each functioning PAN-NET syndrome in patients with advanced disease requires a tailored, multimodal approach of supportive, surgical, interventional, hormonal, and antiproliferative therapies. Strategies that result in a reduction of tumor bulk generally also significantly reduce patient hormonal symptoms. Cytoreductive surgery, removing 70% to 90% of visible disease, can be considered for patients with functioning tumors when feasible. Alternative locoregional therapies include radiofrequency ablation and transarterial bland chemo or radioembolization. These target liver metastases where NETs often spread. Somatostatin analogues, or SSAs, have shown anti-hormonal effects in case reports and small series of patients with hypercalcemia due to PTHrP production. These medications work at the tumor level to reduce hormone secretion. When dedicated supportive therapy for a functioning PAN-NET syndrome is insufficient, palliative SSA treatment can be initiated. For more aggressive disease, PRRT, chemotherapy, everolimus, or sunitinib should generally be reserved for SSA refractory cases. The capecitabine-temozolomide combination showed a 40% response rate in grade 1 to 2 pancreatic NETs in prospective trials, while streptozotocin-based chemotherapy has been used for nearly 50 years in functioning PANNETs. These aren't just statistics, they represent real options when hormone control becomes challenging. First, ensure you've had comprehensive testing. Ask your healthcare team, have my PTH and PTHrP levels been measured along with my calcium? If calcium is elevated, request urgent assessment for hydration status and consideration of bisphosphonate or denosumab therapy. Second, optimize your hydration. Aim for at least 2 to 3 liters of fluid daily unless your doctor has restricted this. If you're experiencing symptoms like confusion, severe fatigue, or muscle weakness, contact your endocrine or oncology team immediately. These could signal dangerously high calcium levels, requiring hospitalization. What is my current calcium level, and how does it compare to normal? Should we measure my PTHrP? Am I a candidate for tumor debulking surgery or liver-directed therapies to reduce PTHrP production? What's the plan if my calcium remains elevated despite initial treatments? What are the second-line options? Should I be tested for MEN1 syndrome given my tumor type? How will we monitor my response? What tests, and how often? Contact emergency services or go to the emergency department if you experience severe confusion or altered consciousness, extreme muscle weakness making movement difficult, severe abdominal pain or vomiting, or irregular heartbeat or chest pain. These can indicate calcium levels reaching critical thresholds. If you're supporting someone you love through this, watch for progressive lethargy, reduced responsiveness, or any of the above symptoms. Don't hesitate to advocate for urgent evaluation. PTHrP-secreting pancreatic nets cause hypercalcemia through a distinct mechanism that requires both aggressive calcium management and tumor-directed therapy. Your next step, confirm your PTHrP status with your medical team and discuss the full spectrum of treatment options, from hydration and bone-targeted agents to tumor reduction strategies. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. The 2023 Endocrine Society Clinical Practice Guideline on Treatment of Hypercalcemia of Malignancy, the European Neuroendocrine Tumor Society 2023 Guidance Paper for Functioning Pancreatic Neuroendocrine Tumor Syndromes, and consensus statements on PTHrP secretion by gastroenteropancreatic neuroendocrine tumors provide comprehensive, evidence-based protocols. Full links are in the description below.